And without further ado, I want to turn over the floor to Dr. Sophia Yu. She is a clinical assistant professor in the Department of Anesthesiology, Perioperative, and Pain Medicine. And she is going to introduce our distinguished speaker today, Rebecca Houston. Sophia, the floor is yours.
Thank you, Dr. Danielle. I am very delighted to introduce Dr. Houston. Thanks for accepting our invitation. And I'm also very delighted to and looking forward to listening to today's topic. So Dr. Houston obtained a PhD degree in applied biopsychology at University of New Orleans. And currently, Dr. Houston is the director of the Rochester Institute of Technology, RIT, Neurobehavioral Research Laboratory, and an associate professor in the Health and Addiction Research Center and Department of Psychology at RIT. And Dr. Houston has been on PIs and co-PIs and multiple grants, and her grants were from NIDA, NIAAA, CDC, New York State Department of Transportation, and U.S. Army Research Institute. So variety of funding sources. And Dr. Houston has published over 54 research articles, which has been focusing on psychophysiological and neuropsychological mechanisms of impulsivity and aggression in the context of substance use and treatments. And her report, the approach has been self-reports, like many of us use. Besides self-reports, Dr. Houston uses structured clinical interviews and biobehavioral assessments and heart rate variability. More importantly and relevant to current talk, Dr. Houston uses event-related potential in the context of substance use disorder. This is the reason why I want to invite Dr. Houston and learn more about research and her findings. So thank you, Dr. Houston, for agreeing to present today's talk. And I'm really looking forward to your presentation. And I will turn over to Dr. Houston at this point. And I will take care of Q&As at the end.
Okay, thank you. Thank you, Dr. Darnell. Thank you, Dr. Yu. And thank you to Ashley for helping get everything organized. At my previous institution, I spent several years chairing our seminar committee. So I know all the work that goes into bringing people in. So first, let me see if I can get my slides to show up properly. All right, does that look correct?
Looks great.
Okay. So again, thank you so much for the invitation to speak and connect with all of you. I am slowly easing back into attending conferences in person and things like that. So getting back into the groove of that excitement that you get when you get to collaborate and have conversations with other people and talk about ideas. And so it feels nice, even if we are over Zoom, it feels really nice to start having those conversations again. I feel like the past 2 years, a lot of us have been a little bit siloed. So today, what I want to talk about is really the current state of the literature on using event-related potentials as biomarkers for substance use outcomes. And really my primary aim is to make the case that ERPs in particular are very ideal tools, not just to be biomarkers, but also to help us better understand the mechanisms of behavior change that are going on through substance use treatment. Dr. Yu mentioned that my training is in a field they call applied biopsychology, which I'm pretty sure was just a way for them to name the degree so they didn't duplicate degrees or something like that in the state. But so I'm primarily trained as a neuroscientist. I have other additional clinical training, but I'm not a clinician. However, I've been really fortunate to be able to collaborate with some amazing clinicians that do work, particularly in this area of mechanisms of change. Most of my work has focused on alcohol use. I've obviously dabbled a little bit with other drugs of abuse in terms of my research. And I know that for a lot of people in this group, obviously, opiates are probably a major interest. And I know that a lot of you have done work in that area. So what I wanted to do today was really talk about ERPs. I know some of you are familiar with them, but I'm going to provide some kind of basic understanding. I can always, move forward more quickly if something is redundant for you. And I am going to present a little bit of preliminary data from my lab, but this is kind of an area that I'm just now moving more into as well. So I think the review paper that I wrote that caught Dr. Yu's attention was sort of my initial focus on getting into this area. And so thanks to a grant from NIAAA, we've been kind of trying to examine some mechanisms of change and using ERPs to look at that in people going through treatment for alcohol use disorder. But overall, I'm going to focus a lot on sort of this, where are we today with understanding the use of ERPs in this context? And then first, I'm just going to talk briefly about substance use disorders and substance use treatment. I don't think I have to convince this group that substance use disorders are a major issue in our current society. I'm sure many of you are familiar with the NSDUH survey in 2020. 40.3 million people, this is ages 12 and up, actually met the criteria for substance use disorder. A lot of those were alcohol use, but those numbers are actually much higher than previous years. Again, if you're familiar with this, you might know that this epidemiological study started using DSM-5 criteria in the most recent version. And so that accounts for a little bit of the inflation because of the way they changed the diagnosis or the criteria. But still, there seems to be a pretty significant increase, suggesting that this is a major public health concern. Substance use disorders are a significant contributor to the burden of disease in most developed countries. Just alcohol alone in the past year, there was a 25% increase in alcohol-related deaths. I know there's a big focus now on dealing with the burden of disease and mortality rates related to opiate use as well. So it's important for us, obviously, to develop effective treatment approaches, which many in your group do, and understand what's going on at many levels. And so one of the levels that I focus on, and I know there are some imaging experts in your group as well, is looking at some of the neural mechanisms that underlie substance use disorders. So again, for some of you, this might be a review. There is a significant literature that has outlined sort of three major areas related to underlying neural mechanisms that seem to be involved in the development and the maintenance of addictive disorders. And although the diagram I have over here on the left comes from Dr. Valkow's and Dr. Koob's work, among others, highlights some of the major brain regions involved, what I want to focus on are these key neurocognitive processes that have been implicated. And the reason I want to focus on that is because understanding these processes and being able to target them when we talk about intervention and treatment is one way that we can get a better handle on what's going on and trying to develop new or adjunct treatments or novel ways to improve treatment efficacy. And I want to point out that a lot of these processes, such as effects on reward processing, the aspects of cognitive control and self-regulatory functions that are mediated largely by prefrontal areas, those kinds of processes are things that happen very quickly. So there's a lot of excellent neuroimaging work out there trying to understand what's going on in the brain when these processes occur and what happens in the context of development of substance use. But because these things happen so rapidly, I believe, and I'm biased, of course, that tools like event-related potentials and other imaging techniques that have high temporal resolution are really ideal for helping us get a better handle on what's going on with these processes and how they may change when someone's going through treatment. And so we've had a large body of animal and neuroimaging work that have helped us delineate these circuits. There have been specific pharmacotherapies that have been developed to target them. And I think, although I am not well versed in the pain research, I think there's some overlap in terms of some of the neurocircuitry that's involved with pain modulation and what's going on as someone starts to develop an addictive disorder. So hopefully that this is of interest to some people. And so in the last few years, there have been a couple of research frameworks that have been developed to help us move away from more categorical diagnostic classification systems. The research domain criteria that was put out by Thomas Insel and his colleagues takes a more dimensional approach to understanding psychiatric diagnoses. Again, I'm assuming that many people are familiar with this. This is this idea that we can focus on some of these dimensional attributes and look at different levels of assessment and processes that might be associated with them to better understand what's going on. And a lot of these domains may cut across many different disorders. So after the research domain criteria idea came out and started taking hold, George Koob and some of his colleagues developed a similar research framework that's called the Alcohol and Addictions, RDoC. And it really kind of honed more in on the key processes involved for addiction. And those are research frameworks. And then Dr. Koob and his group developed this more clinical framework that they call the Addictions Neuroclinical Assessment, or ANA. And so again, this is designed to be a more clinically oriented approach rather than just a research framework that builds on the idea of RDoC and AARDoC. It's all grounded in this neuroscience framework that allows us to examine some of these domains or dimensions to better understand how we can classify and even assess addictive disorders. And so I'm not going to go into a lot of detail about this, but I wanted to provide the idea that understanding some of these key neurocognitive processes and how they may be impacted as addiction develops, but also when people are going through treatment, may be a key area for helping to understand what's going on and then hopefully target those processes in treatment. And so the three key functional domains that are proposed in this framework line up with those main cognitive processes that you see in the overall model of the neural mechanisms that underlie the development of addiction. And so a lot of my work has focused on this idea of executive functioning, constructs like cognitive control. A lot of what I've done in the past is related to impulsivity and the inhibition of behavior like aggressive behavior. Incentive salience fits in with this idea of reward and certain cues being more rewarding or being conditioned. And then negative affect or negative emotionality is also a major area of research in substance use, as again, I'm sure many of you may know, because people may drink to alleviate that negative emotional state. So I just want you to keep in mind that there are these key kind of neurocognitive processes that may prove to be useful as targets for interventions. So when we talk about substance use disorder treatment, there are a lot of different treatments. There have been many different treatments that have been developed and empirically validated. Probably one of the most popular is cognitive behavior therapy, but there are others. Motivational interviewing, a great deal of work focuses on the motivation to change, contingency management techniques, and then there are also a lot of pharmacotherapeutic approaches that have been investigated, particularly with relation to alcohol use disorders, I think. Some of them are FDA-approved medications, but I think the number of off-label applications is probably has even more research devoted to it. Despite all of these, the relapse rates are still high. So the estimates range, but a couple of recent studies have reported like a 40% relapse rate in studies with cognitive behavior therapy. But again, that's just one representative example. In addition, studies that have tried to compare the efficacy of different treatments have basically shown that there doesn't seem to be any kind of difference in the treatment. The main takeaway is that if you receive treatment, you're more likely to remain abstinent or be successful in your substance use disorder treatment goals, I guess. And so obviously, I don't think there've been a study that has compared every possible treatment, but there is a long history, again, in the alcohol literature, going back to Project Match, which was started in the 1990s, that compared cognitive behavioral approaches with a 12-step facilitation and a motivational interviewing approach. And a lot of work has come from that has basically shown no major differences. There have been more recent studies that have compared some of these psychotherapeutic approaches with pharmacotherapy. And again, there's a little bit of variability in the findings, but for most studies, if you get treatment, then you do better. And it doesn't seem to matter what treatment. And it doesn't seem to be that you can match up a certain type of treatment with certain individuals necessarily to increase the effectiveness. So more research has really started to focus on, okay, are there easy ways that we can predict treatment outcome for a given individual based on something like a biomarker? And so again, a lot of research has examined neural biomarkers. There's biomarker research related to genetics that has a long history, proteomics. There's a big interest in like the gut microbiome now. And there is quite a bit of work looking at some of these functional brain measurements as potential biomarkers. So one question I think that comes up when people are talking about using a biomarker is, okay, so if you can study something to see if it's predictive of treatment outcome, what does that mean in the real world? What does that do for us in the clinical setting? Certainly, there may be some instances where somebody could bring in people and put them in the fMRI scanner, but probably for most clinicians, I'm guessing they don't have that option. And so this is one of the reasons why I think event-related potentials might be useful in this context, because more and more EEG data is becoming cheaper and easier to gather. You don't need a lot of fancy equipment, and it doesn't cost that much. So that's one of the things that I'm going to talk a little bit more about. So I'll talk a little bit about this use of ERPs as a biomarker. And then I guess the main takeaway that I want to talk about towards the end of my talk is this idea that in addition or going beyond just a biomarker for treatment outcome, we should really be trying to understand what's happening as people are changing their behavior. So what's happening when someone is changing their drug use and they've got concurrent changes then related to recovery. So we know that when someone stops using, there is some recovery of cognitive function. And that increases their chances that they're going to be able to use the skills and things that they learn during psychotherapy, like some of the skills training that happens during CBT. But this more recent push is trying to understand how those, what else is changing concurrently with those changes, rather than just does it predict whether they remain abstinent or not. So I hope that makes sense. So that's kind of a focus that I am trying to move toward and trying to get a better handle on. So how can we use ERPs to do this? Let's see. Okay. So it's really about understanding the how treatment works rather than just does the treatment work. All right, so I'm going to do a bit of a pivot here and talk about just EEG and event-related potentials. Again, I know some of you may be familiar with these, but it sounds like there may be people that don't know much about them. And so I'll throw up the slide that I throw up for my undergraduate students, where, I just kind of summarize, EEG is basically measuring that electrocortical activity that's given off at the surface of the scalp. And so it's this essentially a summation of synchronous activity of a large group of neurons that are kind of oriented the same way in the head. And so we're measuring that electrical activity that's given off by the brain. And then we can actually go in and epoch or chop that EEG into little chunks where we can specifically look at changes in the EEG activity in response to a specific event. And so ERPs are a reflection of these changes that are tied to a specific event. Oftentimes it's a stimulus that we present to the individual, but it might be their response as well. We can look at changes in brain activity when they make a certain response. So again, I'm showing my bias here, but when we think about trying to understand neurocognition and biological assessments of that, there are a lot of advantages to EEG and ERP. The biggest advantage is that it has high temporal resolution. So it's able to measure brain activity on the order of milliseconds. That's a challenge for some of the other neuroimaging techniques that are out there. Of course, the biggest drawback for this approach is that we don't get the high spatial resolution. We don't get the detailed image of the brain structures. So we don't know where in the brain exactly it's happening because we're getting this, summative response from multiple potential generators in the brain. However, I mentioned before that when it comes to substance use, those key processes that we believe contribute to the development and the maintenance of addiction, those are things that happen very rapidly. So the processes in the brain that are occurring quickly. And so ERPs present a potential advantage in reliably assessing those changes. Now, there are other techniques that have high temporal resolution, like MEG. MEG would also be great for this. MEG, though, has some other logistical barriers. There aren't that many MEGs readily available out there. It's a little bit expensive. And so I know that there are some people doing really cool work with MEG, especially looking at mechanisms of behavior change. So they've looked at motivational aspects and how that's changing over the course of treatment for substance use. But MEG is a little harder for the average person to get their hands on. So event-related potentials, they've been shown to have excellent reliability. Many studies have demonstrated that in terms of test-retest, for example. As I mentioned, it's pretty low cost. Nowadays, there are so many options for being able to gather EEG and ERP data that you really don't even need any kind of fancy setting or equipment. When I first started learning this in graduate school, there were only a few companies that you could really trust their equipment. But now there are so many options out there, and you have a lot of options in terms of where you can gather the data. So the EEG sensors can be used in a lot of different environments. You can have people wearing EEG sensors continuously if you want to gather sort of quite a bit of data. So that gives the ERPs a little bit more flexibility in terms of what you can do with them. Compared to some of the other neuroimaging methods, EEG and ERPs are pretty tolerant of subject movement. If for some reason you're looking to study auditory processing of some of these key constructs, or you're using stimuli that are auditory in nature, the EEG doesn't have some of the auditory interference that you might find with other types of neuroimaging techniques. Obviously, you don't have to go into a scanner. Now, I know that there are probably some scanners that are less claustrophobia inducing than others, but if that's an issue for participants, then that's something to consider. And similarly, you know, the size of the participant or the patient doesn't make a difference in the EEG. And it could be a physical barrier for some other neuroimaging settings. And the reason I mentioned that one is because I've also done a little bit work looking at obesity and the processes that overlap between food addiction and food cues with substance use disorder. So obviously, I feel like there are a lot of logistical feasibility advantages, and then of course the main advantage being that ability of ERPs to capture that temporal processing that is occurring so quickly. I mentioned the low spatial resolution is a disadvantage. And then there are other disadvantages to EEG too in this context, but I think a lot of those span other neuroimaging techniques. For example, we don't have a lot of methodological standardization. So one person might be assessing cognitive control using a certain type of task. Another person might be assessing it using a completely different task and stimuli. So that's something that I'd actually like to see coming more to fruition in the future, is a little bit more standardization, like you see in neuropsychological domains, for example. And then designing the actual paradigms, there are some constraints when you're trying to elicit certain ERPs. And then finally, just the ecological validity. And that's true for any of these things that we're measuring in the lab. We're trying to measure constructs like cognitive control and map that onto processes that are occurring in the real world when someone's faced with the temptation to lapse, for example. So I'll talk a little bit more about that later. Now, when we talk specifically about using ERPs for understanding substance use disorder treatment outcomes, again, that high temporal resolution is really critical for those key processes that we're interested in. And I also want to mention that ERPs can show differences in neurocognition, even if there's no differences in the behavioral performance. And again, that may be true for other neuroimaging approaches as well, but it is something that's been well established in the literature using ERPs in substance use. And so I'm thinking that might actually be something that's useful as you see improvements over time. You may see changes in behavior where someone does well in their behavioral performance, but it may be that at the neural level, they have to allocate more resources basically to perform at that level, similar to somebody who doesn't have an alcohol or substance use disorder. All right, so I'm gonna go through some example event-related potentials briefly and just talk about what we know in terms of their use as biomarkers of treatment outcome. By far, the most popular ERP is what we call the P300. If you've heard of ERPs, this might be one that you've heard of. This can be elicited in a lot of different ways. Very broadly speaking, it represents attentional allocation towards a stimulus. There's theory about it representing a repeated updating of the memory context when you're exposed to a certain stimulus and then you're trying to make a decision about subsequent stimuli. Some people refer to it as more general index of cognitive efficiency. And this is elicited in an oddball task. So a very basic oddball task would be presenting a non-target stimulus 80% of the time and a target stimulus 20% of the time or less. So I might tell you you have two tones. One's a high-pitched tone and one's a low-pitched tone. Every time you hear that high-pitched tone, I want you to press a button. That high-pitched tone is the target, and it's going to occur only 20% of the time. When that happens, you get a big shift in electrocortical activity to those target tones, those rare tones, and we call that shift the P300. So this graph here, I'll point out that on the vertical axis, it's showing you the amplitude or the change in electrocortical activity in microvolts. Positive is plotted down in this graph. You'll see sometimes it's plotted up. Both are acceptable in the literature. And then the horizontal axis is showing us the latency. So if the stimulus onset occurs at 0 here, here are the changes that occur in terms of brain activity. And so what we can do is we can measure the timing, the latency of when the P300 occurs. We can measure the size or the magnitude of this electrocortical deflection. And so that amplitude or size, it seems to be a reflection of this cognitive efficiency. So the P300 has been around for, I don't know, 50, 60 years. There are actually two types of P300. The P3B is what I just described to you. So it's usually elicited by neutral stimuli, stimuli that don't have a, that the person comes to expect in the task. The P3A or the novelty P3 is elicited by some kind of unexpected stimuli. So if I did the paradigm I just described to you with the two tones, but 10% of the time you heard the high pitched tone, the target one, and 10% there were just random noises, then that would elicit this P3A. So it seems to represent the processing of novel stimuli. It's more frontally oriented. And so some people talk about it as voluntary versus involuntary attention. We know that these two ERP components have different neural generators in the brain. These are some of the classic studies looking at the P3B. So you can see these are very old, and that also will account for using this stigmatized term. So usually I stick to alcohol use disordered individuals. But these are some of the original studies that showed in those with an alcohol use disorder, using just a very neutral task, you see a reduced P300 compared to those that are the controls. And so those are depicted in blue here with the alcohol use disordered group in orange. This is something that's been replicated time and time again using a variety of P3B tasks. The graph on the right is showing you something similar, but with people with a variety of different drug use dependence disorders, cocaine, alcohol and cocaine, or opioid. Again, this was back in the day when it was still a dependence diagnosis. But the main takeaway here is all of those groups have a smaller P3 amplitude compared to the groups that didn't have a substance use disorder. Most of the time, these individuals show impaired behavioral performance, so they don't do as well on the tasks. This has been demonstrated with auditory stimuli. It's been demonstrated with visual stimuli. Another way that the P3 can be used is to present the individuals with meaningful stimuli. So if we present people with an alcohol use disorder with pictures of alcohol, particularly if they're tailored to the person's favorite types of alcohol, then what you see is a heightened P3 response. So even if they're not the stimulus they need to make a decision about, they're not the target stimulus, you get this automatic allocation of attention because this is something that's very salient to the person. And so this graph is, again, one of the classic studies. There have been subsequent studies that have replicated this, where those with an alcohol use disorder show a larger P3 response here in the darker line to alcohol, or they call it the craving block in this study, but alcohol stimuli, whereas you don't see that difference in those without a disorder. This has been shown with pictures and words. And so these are some of the kind of basic differences that we see. And so we think this is linked to, or it has been linked to, craving and attentional bias towards drug cues. It's been shown in other drug use disorders as well. Okay, so when we talk about substance use disorder treatment outcome and the P300, multiple studies have shown this lower P3 to neutral stimuli, so the P3B actually predicts relapse. And it's been shown when you look at the post-treatment period, 3 and 6 months later. We've also seen that when people are first detoxified, if they're alcohol use disordered, again, the smaller P3B is going to predict relapse afterward. In addition, if you've got studies that have looked just at treatment completion, so whether people stayed in the treatment or not, their baseline P300, both using P3B and P3A tasks, also predicts treatment completion. And I think the P3A results here, so this is some work that I actually was involved in, those results suggest that, or are tied to executive functioning deficits. And so if you have people entering treatment and they have these executive functioning deficits, it's harder for them to actually follow and learn the skills that they need to learn during cognitive behavior therapy. And so that's why there's been an increase in interest of kind of cognitive remediation kind of approaches in substance use as well. So the P300 probably has the most research in terms of just differences between those with an alcohol or drug use disorder and as a biomarker. Some preliminary data that I have, we tried to look at the P300 in those that were seeking alcohol treatment. So we recruited people from the community through advertisements. And we had 35 men and women that met criteria for alcohol use disorder. They went through 12 weeks of CBT. This is the CBT approach that we used in that project match that I mentioned. And we assessed them before and after treatment, and then 3 and 6 months post-treatment. And then we assessed all the things. And we were primarily focusing on cognitive control. And so we tried to assess that through a variety of tasks and self-report measures, as well as event-related potentials. And so we saw reductions overall in drinking behaviors. This is the mean number of drinking days per month using the timeline follow-back interview, the number of drinks that they did drink that they had each day when they did drink, and probably the measure that seemed to be most tied to our ERP results was the consequences of drinking. And so instead of just measuring the drug use behavior, I think it's really important to pay attention to what are the actual consequences the person are experiencing, and are those changing across the treatment? So we saw reductions across the board on those. The data that I'm going to show you here is using an auditory perseveration task. This is a P3A task. It's a little different from the P3A task I described before, but this is basically, again, an auditory task where you have 2 different tones. But what you're asking the person to do is press a button on the left if they hear the high-pitched tone, and a button on the right if they hear the low-pitched tone. And then every once in a while, there'll be a white noise burst, and that's their signal to then switch the mapping of the responses. And this occurs throughout the task. And so this really gets at that cognitive flexity, cognitive control component that we are interested in assessing. And it elicits a P3A, in particular to that white noise burst, the signal for the switch. When we looked at pre-treatment and end of treatment, we didn't see any difference in the behavioral performance. This is probably because everybody did pretty well on the task. I've tried this task. I'm not good at it, but I'm not sure what that means. But most of our participants actually did pretty well. They didn't make that many errors. A perseverative error is if they kind of continued with the same pattern, they didn't actually make the switch. But we did see changes in their P3 amplitude. So the amplitude increased and the latency decreased. So I mentioned amplitude decrements because that's what's most commonly associated with drug use disorders. But sometimes you also see a slowing of the processing. So the latency of the P300 represents the stimulus evaluation time. So in other disorders like schizophrenia, you see a really prolonged latency of the P300 because they need more time to evaluate the stimulus. In addition, our change over the course of treatment was correlated with their drinking and those consequences that we saw. So those changes that we saw. So before I move on, I wanted to mention too that, you know, in these analyses, again, they're preliminary, small sample, but we controlled for how many treatment sessions they attended. And we also did some analyses where we controlled for baseline drinking versus baseline levels of consequences. And we still see the change in P300. Now, we also gathered that data at 3 and 6 months. So with the drinking, you see the typical curve where it starts to creep up just a little bit. So people do start to drink a little bit more. And we actually don't have differences in the P3 at that point on this task. But we have a lot of other data that I just haven't had the chance to process and look at yet. So we have stop signal data. So it's a response inhibition task. We have flanker data that has a reward component to it. So again, we're trying to tap into some of those key cognitive processes that are associated with the development of addiction. In addition, we have data that's more fine-grained, where we brought a subsample in and we assess the ERPs every 3 weeks during treatment as well. And so that's what I'm really interested to see is how are things changing? What's the change pattern and how is that related to their overall outcomes later on? So that's just a peek at that. I know I don't have much time left, so I just wanted to mention there are other event-related potentials that have been associated with some of these key processes. They've been shown to be affected in alcohol and substance use disorders, and a few of them have been shown to be predictive of outcomes. So the N200, I'm surprised there's actually not more research on this because it's thought to reflect cognitive control to some extent. You see this elicited oftentimes in inhibitory control tasks. The late positive potential. I was excited to see that you had Dr. Eric Gardner as your last speaker because he's been using the LPP in some of his work with his MORE intervention. And so I know that, you know, he's used that in patients with pain and opiate use, but he's shown that the motivational salience, particularly to pleasant stimuli, is really important. And so the LPP is thought to reflect motivated attention. It's often examined in the context of emotional processing. So if you see a stimulus that is emotionally arousing, whether it's positive or negative, then you're going to have a larger LPP than to just a picture of a fork or something like that. But this has also been applied to that sort of attentional capture aspect, that motivational salience for drug cues as well. And in one study, they linked the LPP to cocaine drug cues to abstinence levels. The error-related negativity is another popular ERP that's been associated with substance use. So basically, this is when you make an error, you get this negative deflection. So you can see the difference between error in the red and correct responses in the blue here. This is actually a study that one of my former students conducted. It wasn't in drug users. I just like the ERP graph because it really shows the difference and what the ERN looks like. She was looking at substance use risk, so it wasn't looking at treatment or major differences. But essentially, spatial location studies have shown us that this is primarily generated by the anterior cingulate cortex. And if you have a substance use disorder, you usually have a reduced ERN because you're not good at monitoring or self-regulating. And so a couple of studies have also shown the predictive value of the ERN for substance use disorders. And then the most recent component that's gained popularity is the reward positivity. So it's also seen sometimes in ERN studies. It reflects reward reactivity. There's definitely some evidence that those with a substance use disorder have blunted reward positivity responses, but there hasn't been any study to date that I've found that shows that how the ROOP is related to treatment outcome. So all of these are just examples of ERPs that can be used that seem to line up nicely with those key cognitive processes. There are many other ERPs, but we know that there's a growing literature that seems to suggest that ERPs can be potential biomarkers. But as you saw, it's kind of scattered. Some studies have focused on one ERP, some on another. They've used different tasks to elicit them. And so I think it'd be nice if we could, gain more consistency in the literature. The other thing that I want to mention, and this is maybe relevant for some of the work that you all do with opiate use, is that a lot of these studies looking at biomarkers have used categorical outcome variables. Did they remain abstinent or not? And this is going to vary depending on the drug of abuse. But I think that if we're going to try to understand how things are changing, this can be problematic for a lot of reasons. First of all, I don't know. It may be different in opiate research, but a lot of people don't just stay abstinent. And they may be able to get back on track after a lapse or even after a relapse, but it's not really a black and white experience for most people that are going through treatment. That distinction between abstinence and relapse is not really theoretically related to the mechanisms that we think are driving the development of substance use. And so that presents a problem when we're trying to interpret our findings, I think. And maybe some people don't want to stop altogether. Maybe they just want to moderate their drinking a little bit or drug use. And so these are all recent articles that talk about this idea of maybe we need to change the way we're looking at this, and maybe abstinence doesn't have to be the goal for everybody. And so I will say that in the preliminary data that I showed you, it was only 35 people, but only one person stopped drinking altogether. So only one person remained abstinent. So that's been my experience in the alcohol treatment world. I don't know what it's like with some of the other drug treatment approaches, probably because, again, there are different factors that are involved, like whether somebody is getting some kind of substitution therapy. Okay, so the last things that I want to mention is that instead of just looking at ERPs as biomarkers, I would like to look at how we can use them to gauge change. And so I've already mentioned this a couple of times, but rather than understanding if a treatment worked or if we can predict whether the treatment will work, understanding how or why the treatment should work. And so, most biomarker studies have just assessed the ERPs pre-treatment and then looked to see if they predicted the outcome. I'm recommending, and my colleagues, that future research in this area should actually examine those changes over time, just like I mentioned that we have multiple assessments throughout and after treatment, and look at those as they relate to changes in the substance use behaviors, the consequences, and other changes that are going on. You're likely to see other mental health changes. I think ERPs are useful because, again, you can easily deploy them in many different environments. They don't cost much. It's easy to get that data. And so it's not cumbersome to the patients. And again, they're really well suited to assess these processes of interest. The last point that I want to make is going back to that framework for research and clinical assessment and looking at this more dimensional approach. So some of the active ingredients for different psychotherapeutic approaches can be well aligned with some of those key processes of interest. And so this is an example from that review paper that we did, where we took one treatment ingredient from CBT, in this case, drug refusal. We identified what those relevant processes are, those key processes, that we need to potentially assess and monitor over time. And then we suggest that there are specific ERP components that can line up well with assessing those changes over time. In addition, pharmacological treatments presumably might also affect some of these same cognitive processes. And so you could, potentially use ERPs to look at those changes in the same way. So it's not just about non-pharmacological approaches. This is a long list of considerations for the future. Some of them are things that you should be doing always in research. Historically, a lot of the research on substance use treatment is on Caucasian or white people. So it would be nice to get some more variability. That's been changing more, but I think at least looking at ERPs, there seems to be still a bias. Using different types of continuous treatment outcomes, so not just looking at abstinence versus, relapse. Also, not just self-report, but using biological measures as well that can suggest that, whether it's urine screens and so forth. Multiple assessments, examining treatment adherence. Not all the studies actually look at how many treatment sessions they actually attended or homework completion during CBT, things like that. And so that's something that in the studies where they did look at that, it does seem to make a difference. That variability in treatment goals reflects the abstinence versus a relapse distinction. And then we don't know a lot about some of these newer treatments or interventions. Another study that I'm doing right now is actually scaling things down to young adults at risk who are binge drinking and using marijuana regularly. And we're trying to first look at some of these processes and how they might differ depending on their drug and alcohol use patterns, but also then engaging them in HRV biofeedback, heart rate variability biofeedback, which is thought to enhance physiological self-regulation. And so some of our pilot data does suggest that you can see changes. I've also done HRV biofeedback in alcohol use disordered patients and inpatient treatment. Other researchers have also shown the effectiveness of that. So we're trying to see, is that something that we can use to help us better target some of these key processes that we know are related to addiction? Okay, I think I went over my time, so I apologize. I have a lot of wonderful collaborators and funding sources to acknowledge, but I'm happy to take a few questions if there's time.
So we have 3 minutes. Anybody have any questions? Put your questions in the Q&A chat box. And while we are waiting, I have just one question. So in the earlier slide, in addition to EEG, you mentioned about MEG, and can you tell me a little bit about what was that?
Oh yeah, I'm sorry. So that's magnetoencephalography. And so it's, instead of measuring the electrical signals that are giving off, it's measuring the magnetic signals that are induced by those changes in electrical activity. And so it's very similar in terms of what you get when you're looking at the data, and it has that high temporal resolution, but it does require high level equipment that's relatively expensive.
Okay, thank you. I will try to look it up. I couldn't find it. Okay, got it. So we don't have any questions yet coming in.
Okay. Also, if anybody has questions, I didn't put my email address up there, but I can, of course, provide it. Anybody's welcome to email me if they have any questions anytime, or would just like to chat.
I can ask one more question. So I believe biomarker and mechanisms are a little bit different. And do you feel like moving forward, the biomarker turning into discover of the mechanisms and developing treatments? Do you feel like we are heading that direction?
I think substance use treatment research is definitely heading in that direction. And there is neuroimaging work in that area. That's quite a bit that's been done in the most recent years. But I think there are some drawbacks. You know, every study has limitations, and I think that looking at these rapidly unfolding moment-to-moment changes is what's kind of the key here. And the fact that if we do think that we can get to the point where we can actually use this at the clinic level, right, as part of a typical intake or something like that, then I think that that's one of the advantages. So I guess yes is the answer to the question. I think we're moving from just, do we have something that can predict treatment outcome, to understanding, okay, what's changing and how can we capitalize on that to then tailor the treatment or make the treatment more effective.
Okay, thank you. So we have two questions, one from Noel Best. What alternative outcomes would you suggest collecting for patients in treatment that may map on to this type of testing?
So I'm not sure if I totally understand, but so I assume you mean other than just substance use patterns and substance use consequences?
So what will be the alternative outcome measure do we need to collect?
Yeah, so we usually collect data on mental health variables that are commonly comorbid, so anxiety and depression and things of that nature. Some people actually collect quality of life types of assessments as well. And I think I mentioned, related to the drug use, if there are any biological verification kinds of outcomes that you can collect, then that's advantageous too. So I'm not sure if that totally answers your question.
Okay, so the last question from Love Monte, very fascinating. Thank you for the insight, and it'll be interesting to see more development with this in research and in clinical practice. Just the presentation on the possibility of using EEG and ERPs in the clinical practice was quite intriguing. It was a comment. Sorry about that.
Thank you.
So that was my point as well. Yes.
Again, I think I said many times, I'm a little biased because I was raised as an ERP researcher, but I really do think that they provide a way for much more to be done in a much more feasible way. We need the animal research, and we need the other neuroimaging work, right, to get the whole picture. But I feel like this is something that you can take to the clinic eventually, and it might really be useful.
Absolutely. Thank you for your great talk.
Thank you so much again for inviting me. And again, anybody's welcome to email me anytime. And I look forward to meeting with some of you later on.
Thank you, Dr. Houston.